Hi, everyone. Just to start out by introducing myself, my name is Julie Gold, and I'm a cancer genetic counselor. And the title of my talk is The Implications of Somatic Testing on Germline Analysis. Just to give a brief introduction to this webinar series. So this is a new initiative in the division. We are trying to save any questions until the end of the webinar, and you're able to type in any questions into the Q&A box at the bottom of the screen. Please also feel free to suggest topics for future webinars. The real goal of these webinars is to provide information to different providers. So this is an oncology-focused webinar, and I'm a cancer genetic counselor. The next webinar coming up is September 9th, and that will be on reproductive genetics and mosaic embryos, presented by one of our reproductive genetic counselors. And if you have suggestions for future webinar topics, we're definitely all ears. Just of note, Sahila Brander, one of the other cancer genetic counselors, presented an introduction to cancer genetics a couple of weeks ago, and that webinar is posted on the website, which might help to give some context for my talk if you need some more introduction. So the goal of my talk is really to go over how somatic testing on tumors can influence our risk assessment, our test choice, and test interpretation for hereditary cancer. It will include some of the various considerations when looking at a somatic result, as well as case examples from some of our genetic counseling sessions. Unfortunately, with these kind of cases, there isn't a specific algorithm for thinking about each one. It's very nuanced. I do hope to provide some of the various considerations, but by no means is this talk comprehensive. And I did want to point out that the cancer genetic counseling team are always available for questions regarding somatic cases and reports, and we'll provide our contact information at the end of today's talk. I have no disclosures related to this presentation. However, I have provided genetic counseling services for PWN Health. So just to start out by giving some introduction to all of this. This may look familiar from the last cancer talk, but I just want to give the basics of cancer development and tumor suppressor genes. So this diagram will show the difference between how a sporadic and a hereditary cancer form. Many hereditary cancer genes that we think about are tumor suppressors, which means their job is to protect us against cancer development. And I did want to point out, which I'll reiterate many, many times, that all cells, including cancer cells, can have mutations or variants. And when we look at tumor sequencing reports or somatic reports, we expect to see variants. However, that doesn't mean that the patient was born with that specific variant. So just to give some context, we are all born with 2 copies of all of these genes, one from our mother and one from our father. Sporadic cancers develop when someone acquires 2 mutations throughout their lifetime. When someone has a hereditary cancer, they are born with one of those mutations already in their cells, and that would be in all of the cells of their body. So they are one step further along in the process of cancer development, and we sometimes describe this as having one less layer of defense. You might have heard of the 2-hit hypothesis. Sometimes these acquired mutations are called hits. So if someone is born with a germline mutation or has that hereditary cancer risk, they do still need a second hit for cancer to develop. And at the bottom of my screen, and in the 2 mutations for both sporadic and hereditary cancer, it points out the concept of loss of heterozygosity, which refers to the concept of having no tumor suppressor gene to protect the body. So some of the differences between germline and somatic mutations are labeled here that I wanted to point out. So germline variants or mutations are inherited from a parent, from the mother or father. Typically, sorry about that. Typically, the mutation is replicated and in every cell of the body, and then it would be passed or have the chance to be passed on to offspring. So typically with most of these genes, they're inherited in an autosomal dominant pattern, which means that half of the children or offspring would be theoretically be at risk for the mutation. In contrast, a somatic mutation is not inherited from a parent. It develops over time and would only be in typically an affected area of the body and not passed on to offspring. So when we're talking about germline testing, that's typically done on blood or saliva samples. And when a patient is referred for cancer genetic counseling and testing is ordered, that's typically germline testing because we're looking for hereditary cancer risk. So this part on the left of your screen. Somatic testing is done on a tumor specimen, and oncologists are typically the ones ordering that type of testing, and I'll go into a lot more detail about that coming up. And again, important to note that all tumors have mutations. Most of those would be somatic mutations, so in the tumor, that affected area. But germline mutations would be in every cell of the body, which would include tumor cells. So when we do a somatic test, we are typically sampling the tumor, but that can show both somatic and germline mutations, and it's sometimes hard to tell the difference. So some things to consider when thinking about somatic testing and somatic reporting. So there are various different types of somatic tests or tumor tests. So some of you might be familiar with are about recurrence risk. So that has to do with how likely the patient's cancer is to return, and that sometimes helps with chemotherapy decisions. There are tissue of origin tests to determine a metastatic cancer and where the primary site of that cancer, where the origin was. There's liquid biopsy tests, which is typically sampling circulating tumor DNA in the blood. And then there's tests that have to do with targeted therapy, which will be the main focus of today. And that is that many patients, especially with metastatic cancer, are getting some sort of somatic panel, and that is to determine if there's a therapy or a treatment that might be most effective for them. And some considerations for that include both analytic and clinical validity, as well as clinical utility. Analytical validity refers to the types of mutations that are validated on a particular tumor panel, the limits of that detection, which I will go through for sure, and the tumor specimen, the quality and quantity of that specimen. Clinical validity is important because somatic labs have different goals for the testing, and a test is considered clinically valid if it helps with treatment implications, so if there is an established treatment or prognostic importance. Clinical utility refers to potentially there being a standard of care treatment or potentially an off-label treatment that might be available for the patient. So an important consideration when looking at these reports is that germline variants may or may not be a high priority in tumor reporting because of the goals of the test and what they're trying to accomplish. So somatic sequencing, I did want to point out that almost everyone will have at least one somatic variant on tumor testing. These are two studies that I'll refer to especially at the beginning here a few times. One is out of Memorial Sloan Kettering and one is out of MD Anderson Cancer Center. I did want to point out that the term pathogenic means a positive result, and we will go into more detail about classifications a little later. So almost everyone will have at least one somatic variant. However, about 42% of patients who get a somatic sequencing panel in these studies had a pathogenic somatic variant. And between 4 and about 12.5% had a pathogenic germline variant. So the rate of germline variants was much lower than somatic variants. And the rates may be dependent based on the variety of the cancer genes assessed. So the different studies tested a different amount of genes. So the more genes we test for, the more chance we have of finding those pathogenic variants. Now I'm going to go into some of the various considerations when we think about looking at a somatic report and what it might mean for the patient in terms of germline implications. And this is where I'll go into more case examples as well. So this chart is from one of those studies that I mentioned, and it reviews patients that had somatic sequencing panels, and then they confirmed if those variants that were identified were purely somatic, so only in the tumor, or germline mutations that would have been in the tumor and the germline samples, or every cell in the body. So to orient you to this chart, the blue indicates somatic only variants, and the green indicates germline variants. So the moral of the story is that the gene that the variant is identified to be in really matters. So you can see BRCA1 and 2 have almost an 80% chance that if a somatic variant is identified, that it is actually a germline variant. And you can see the genes MSH6 and PALB2 are also examples of genes that have a fairly high germline rate. And then there are a lot of genes that have a very low chance of being germline, which include the APC gene, the MLH1 gene, the TP53 gene. So these are all genes that we don't get so concerned when we see someone have a somatic variant in one of those genes, unless their clinical features are suggestive of that condition, which is something we're able to review when we take a full medical and family history. So it really depends what gene the variant is in for how suspicious we are of it being germline. And we do use clinical information as a guide. However, I do want to point out that many pathogenic germline variants, the patients will actually not meet clinical criteria for testing. So this one study found about 35% of patients that had a germline variant actually did not meet the standard criteria, which does raise issues with getting insurance coverage for some of this confirmatory testing, which I'll be able to review in a little bit. And then also that tissue type does not always correlate with the mutation that's identified. So in this study, about 41% of the variants were actually concordant with the cancer type, which means a lot of them were not. So that could be like a lung cancer in a smoker with a BRCA mutation. That probably isn't the reason why the lung cancer developed, but maybe still important for the patient's future cancer risk as well as for relatives. And then we always think about, is the gene that a variant identified even associated with germline risks? So as I go through case examples, you'll notice that I don't comment on a lot of the variants identified on somatic tests. And that's important to again, remember that the labs have different goals for the testing. So many of the genes on a somatic test do not confer a known risk for hereditary cancer. Therefore, it might not be helpful to confirm if a variant in one of those genes is germline, and testing for those genes might not even be clinically available. I did want to point out, this is the National Comprehensive Cancer Network, which lays out guidelines for testing strategies as well as for management based on results. And they actually have started to comment more recently on tumor testing and how to use those results. So they actually specifically comment that finding a BRCA1 or 2 mutation warrants germline genetic testing regardless of the patient's clinical history. So regardless if they have a personal or family history consistent with hereditary breast and ovarian cancer, and also regardless of tissue type. So it doesn't matter what tumor the variant was identified in, and that's again because of that very high rate of mutations identified to be germline. And NCCN specifically comments that variants in some of those other genes like TP53, STK11, and PTEN rarely warrant germline testing unless the clinical and family history is suggestive. And that's because almost never are those variants actually germline. And they are very common variants in tumors. This guideline also notes the technological limitations of somatic testing, which I'll be able to review a little bit more later. So the next consideration, and something we get questions about a lot, is allele fraction. So variant allele fraction is something that a lot of somatic panels can produce, and that basically refers to what percentage of the alleles actually carry a variant. So if we expect that we inherit one copy of our gene from our mother and one from our father, if we inherited a variant from one of our parents, we would expect to be heterozygous, meaning that 50% of the alleles would have that variant. So the variant allele fraction would be 50%. So we typically expect that if someone has a germline variant that we would see that 50% number, but it's important to note that this is highly variable based on the tumor's characteristics. So the labs can typically report the tumor percentage in the sample, which can help adjust for this variant allele fraction. And some labs automatically report the variant allele fraction. Some labs only report it if a provider asks for research purposes. And I'll go into some of the reasons why and why not it might be helpful. So going on to our first case example, this is a patient that was diagnosed with metastatic prostate cancer at age 76. And it was an Ashkenazi Jewish family, and the family history included the patient's maternal grandfather who was diagnosed with pancreatic cancer, as well as the patient had absolutely no information regarding his paternal family, so a non-informative part of the family. When I saw him, I was able to review his somatic testing, and I am pointing out one variant that was identified in the BRCA2 gene, and the allele frequency is 47.41%. So pretty close to that 50% that we would expect to see if the patient had an inherited germline mutation. I do want to point out the specific variant. So the nomenclature refers to a specific common Ashkenazi Jewish founder mutation in the BRCA2 genes. So whenever we see a founder mutation, it raises our suspicion for it being a germline mutation because we know it's a common mutation to be germline. As I kind of referred to on the last slide, we take the whole medical and family history when we see a patient regardless of the somatic results, and that's because of some of the limitations that I'll explain shortly. And we did order more comprehensive testing for genes also associated with metastatic prostate as well as pancreatic cancer, including the BRCA2 gene. And the results from that were kind of not surprisingly confirmed that BRCA2 mutation, that being the common Ashkenazi Jewish BRCA2 mutation. So this is an example of the allele frequency kind of working how it's supposed to. So close to 50%, it confirmed to be germline. And as we are probably aware, BRCA2 is associated with a high risk of breast and ovarian cancer in females. And this patient did have daughters who were then able to be tested and know if they needed increased surveillance or consideration of prophylactic surgeries based on this information. And on the top, on the patient's somatic results, it points out that the patient, this result had treatment implications for the patient, that PARP inhibitors have been shown to have increased efficacy in someone who is BRCA positive in certain tumor types. So this patient actually did go on a PARP inhibitor based on these results. This is the next case example, which is a patient who was diagnosed with ovarian cancer at age 51. The patient's mother was diagnosed with ovarian cancer in her late 60s, and the patient's sister was diagnosed with breast cancer in her 30s. And the patient reported that the sister had had positive genetic testing that led to the sister getting a double mastectomy as well as a oophorectomy, or removing the ovaries and fallopian tubes. But she didn't have the actual report or any further details. And the patient's father was diagnosed with prostate cancer at age 70. I apologize, some of these somatic reports are a little bit blurry because they come from screenshots from the chart, but I'll point out the important parts. So the somatic test showed a BRCA1 mutation in the tumor, and it also pointed out at the bottom here the treatment implications. So again, PARP inhibitors would be important for the patient, as well as potentially platinum-based chemotherapies that might be more effective in someone with a variant in the BRCA1 gene. The BRCA1 mutation was identified at 90% variant allele fraction, and there was also a TP53 mutation identified at 57% for that allele fraction. But remember, BRCA1 mutations in tumors are much more likely to be germline, whereas TP53 mutations hardly ever are germline. All patients with ovarian cancer are recommended to have genetic testing, so a multi-gene panel was ordered, not just what was found on tumor sequencing again. And the results came back that the patient tested positive for that BRCA1 mutation. And it's important to note that that's likely related to the patient's ovarian cancer diagnosis. It does have treatment implications. And we postulated that the 90% allele frequency might show loss of heterozygosity in the tumor, which may be the explanation for the tumor progression and why we're not seeing a second hit in the BRCA1 mutation on the somatic report. This patient had children and other siblings that now know that they were at risk for BRCA1 and possibly BRCA1 related cancers if they also tested positive. So this was, again, important for the patient for treatment reasons, but also for the relatives in terms of surveillance or prevention. This is a case example of a patient who was diagnosed with colon cancer at age 33. On the patient's colon tumor, it was identified to have loss of expression of the MLH1 and PMS2 proteins. And this is a screen that's done on all colorectal cancers that tests for the possibility, it's a screening test to detect Lynch syndrome. So this result shows a possibility of Lynch syndrome, or that the tumor is behaving in a Lynch-like way. And just to reiterate what Lynch syndrome is, it is associated with an increased risk of colorectal, uterine, ovarian, gastric, and other cancers as well. The family history was not so striking. It was a very, very large family, lots of siblings, lots of aunts and uncles, and the only cancer history were a great aunt and uncle on the maternal side that were diagnosed with colon cancer, one at age 50 and one at age 65. On this patient's tumor testing, they were identified to have two variants or two mutations in the MLH1 gene. I wanted to point out this bottom one here because the variant allele fraction is 50%, so right on the nose for when we think it should be a germline mutation. And then we did germline testing, a multi-gene panel, and we did not identify an MLH1 mutation. There was a variant of unknown significance detected in the MSH2 gene, but we basically treat variants of uncertain significance as innocent until proven guilty and don't counsel it as a positive result. So this is important because this patient is now not considered to be at higher risk for uterine or ovarian cancer. She has no family history, and now we know she does not have Lynch syndrome. So prophylactic surgery or extra screening is not indicated for this patient, and genetic testing would not be indicated for the family based on her history. But they do, some of these relatives are closer related to those ones that had colon cancer, so they could still consider genetic testing related to that history. So to summarize related to allele fraction, this is from that same paper as previously, but it graphed what the allele fractions were for both somatic only variants and variants that ended up being germline. So you can see on the germline side on the right, this blue section, that the median allele fraction for germline variants was 46%, so pretty close to that 50%. However, the range was 13 to about 94%, so that doesn't really help us too much. And on the somatic side, so this green side over here, we're seeing a median allele frequency of 33%. But the range was about 1% to about 96%. And you can see in the middle here, a lot of somatic only variants hover around that 50%. So basically, in summary, we don't think we can really determine if an alteration will be germline just based on the allele frequency. And that's important because it's influenced by the proportion of tumor cells in the particular sample. So those numbers that are reported are specifically for that precise sample at that precise moment in time. And if we biopsied another spot of the tumor or another time, those allele fractions could be very different. So the moral of this story is to think about germline implications if a patient's personal and family history, as well as their somatic results might suggest, regardless of allele frequency. So some technological and reporting considerations to think about here. So there are different ways that laboratories classify variants. So somatic laboratories have different schema for their classification than germline laboratories. And that's, again, due to the different reasons for doing the test. Somatic labs are typically looking for treatment implications, versus germline labs are looking for that hereditary cancer risk. So these are some of the databases and levels of evidence that are used for classification of somatic variants. Whereas for germline variants, typically labs are working off of the ACMG guidelines. And at the bottom here, I wanted to note that both germline and somatic classifications do range from this negative result called benign to a positive result, pathogenic. But there are different criteria for how to get to these classifications, and it is possible that a variant that is classified as, say, pathogenic in the somatic sense might not be pathogenic in the germline sense. So it's important to know if that variant is actually actionable or considered a positive result. And again, I mentioned variants of uncertain significance in the germline are often, we use that mantra, innocent until proven guilty, because very often they are reclassified to be likely benign or benign. However, there are some providers that would consider using somatic variants of uncertain significance differently for possible treatment options, depending on the patient's other options that are available. So in theory, as I mentioned a few times, germline mutations should be in all cells of the body, including tumor cells. But there are a few different reasons why a germline mutation may actually not be detected in the tumor. So that has to do a lot with technological limitations. So the region that the variant is in might not be well covered by the methodology or not covered at all. So some laboratories do what's called full gene sequencing, so going letter by letter through the gene, whereas other laboratories or other tests do hotspot testing and only testing parts of the gene. Deletion duplication analysis is not always done as part of certain panels. And then there also is a possibility of a loss of the germline mutant allele. It should be rare. This one study reported that 92% of germline variants were retained in the tumor, but it definitely can happen, and that could be treatment related regarding reversion events. So BRCA1 or 2 mutations could be lost in a patient who has had platinum therapies in the past. Other reasons why the germline mutation might not be detected in the tumor could be that the germline mutation was actually mosaic, which means that the mutation is present in some cells of the body and not in others. So maybe it's not present in the tumor cells. It's important to think about if the germline gene was even part of the somatic panel. So important to look at what genes were tested. And then the reporting protocol might be different. So some laboratories report alterations that are found in both the tumor and the germline. Some report tumor only. And I'll go into an example of that in a little bit. And then nomenclature, how the variants are named, can be really important. So tumor alterations can be listed differently than alterations in the germline. So that depends if something is listed or the variant is named on the protein level or the nucleotide level. It depends what isoform is used, and I'm getting kind of in the weeds here. And it's also for deletions and duplications, it might be important to know how large the deletion or duplication was so that we can appropriately test for it in the germline. So again, it's important to refer patients for germline genetic testing if their clinical history suggests, regardless of their somatic results. So even if their somatic sequencing was totally negative, found nothing suspicious, if their clinical history is suggestive, there's a lot of reasons why they should still be referred. So this is another case example of a patient who was diagnosed with colon cancer at age 35, and the patient also had a history of polyposis, including serrated adenomas and inflammatory polyps. It was an Ashkenazi Jewish family, and the family history included the patient's sister, who had a history of colon polyps starting in her teenage years. And those included mixed polyps, some juvenile, and the patient's sister had a colectomy when she was 28 years old. The patient's father was diagnosed with colon cancer at age 47 and also had a history of multiple colon polyps. The patient's paternal grandfather was diagnosed with colon cancer at age 53. And the patient's nephew, so that sister that I mentioned, her son also had colon polyps more recently. So this is the patient's somatic test report that was available. And I do want to point out that this patient was identified to have a variant in the BMPR1A gene, which I'll go over a little bit more, but that's important to think about here. And even more important is this comment at the bottom, basically that this test is called, they collect a tumor sample as well as a blood sample, which they call the matched normal sample. And this test only reports somatic variants that are not in the matched normal, so that are not germline variants. They do have a consenting process, so if a patient consents to receive germline results, they will report that information, and that's used to preserve the patient's autonomy so that they have the choice if they want that information about hereditary cancer risk or not. And at this time, the patient had not consented to that to those germline results, so it was not reported in this case. So we knew looking at this report that all the variants that we saw were somatic, but thinking about that two-hit hypothesis again, we were basically looking to see in the germline if we could find a second hit in that case. So pointing out what BMPR1A is associated with, it's associated with a syndrome called juvenile polyposis syndrome, which is associated with juvenile polyps, which are hamartomatous or adenomatous histology. And it's also associated with an increased risk of cancers in the colon, gastric cancer, small bowel cancer, pancreas cancer, as well as some others. I wanted to point out that the management for patients who have a BMPR1A mutation actually starts at age 15. So they receive colonoscopies and upper endoscopies starting at that age. And this patient had a bunch of nieces and nephews and other very young relatives that would have been at risk if this was confirmed to be a germline mutation. So not so surprisingly, given all the family history, we did identify a germline mutation in the BMPR1A gene. I do want to point out that it is a different variant than the one reported on the somatic panel. This is a large gene deletion of the BMPR1A gene. So we think of this as really the first hit, the germline mutation that the patient was born with, and then the tumor developed that second mutation in the BMPR1A gene that was reported on the somatic panel. And the last consideration that we think about with somatic testing that I'll be reviewing today at least, is that it's important to think about if a germline mutation is actually the reason that the tumor happened, so driving the tumor, or if it might be an incidental finding or a random pickup. And remember that germline mutations would be in all cells of the body, including tumor cells. So just because a germline mutation is identified in a tumor does not mean that it contributed to the tumor progression. So this is a case example of a patient who was diagnosed with ovarian cancer at age 66. She was also diagnosed with lymphoma at the same age, and it was an Ashkenazi Jewish family. And the family history was not so striking. It included a maternal uncle that was diagnosed with lung cancer after age 70. And the patient reported that this uncle had had an ileostomy earlier in his life, so she thought that he might have had colorectal cancer, but that was unconfirmed at the time. So this is the patient's somatic report, and I highlighted this variant in the APC gene labeled I1307K. And you can see at the bottom that this variant that was identified is not helpful for the patient's treatment. There's no FDA-approved therapies or possible clinical trials available based on this information. But I do want to explain what this variant is. So this is a founder mutation in Ashkenazi Jews that between 6 and 10% of all Ashkenazi Jews actually carry. And this is thought to create a hotspot or a hypermutable area in the APC gene, so leads to those somatic mutations, and is associated with a elevated risk of colorectal cancer, so about 1.5 to 1.75 times the average person's risk. And that's very different than if you look up other variants in the APC gene, which are associated with a condition called familial adenomatous polyposis, where patients typically are developing hundreds or even thousands of colon polyps very early in life and have an extremely high risk of colorectal cancer. With this variant, we do start screening for colon cancer at a little bit of a younger age, so starting at age 40, whereas most individuals are starting at 45 or 50 at this point, so it could be helpful for patients to know what age to initiate colonoscopy screening if they are carrying this variant. So this patient's germline results came back and confirmed this I1307K variant in the germline. You can see that instead of actually calling it a pathogenic variant, they call it an increased risk allele, which is trying to be very specific that it does not confer the same risk as other APC mutations. And again, when we see founder mutations like this, it's unsurprising when that's actually confirmed to be a germline mutation. However, it's important that this is not believed to have contributed to her ovarian cancer development, nor is it important for her treatment. But this can be helpful for her family members because the patient had children that were approaching age 40 at the time, so they were recommended to get testing to determine when they should begin getting colonoscopy screenings. And this is the last case example that I'll go over today, which is a patient that was diagnosed with an astrocytoma at age 85. It was an Austrian family, and the patient's mother was identified to have breast cancer at age 63. Her maternal grandmother was diagnosed with an abdominal cancer, potentially a gynecologic cancer. We didn't know the age, and the patient's paternal grandmother was diagnosed with colorectal cancer at age 88. This is the patient's somatic findings. So I wanted to point out 3 of these variants. So the one at the bottom is a variant in the CHEK2 gene, and this is another one of those common founder variants in Europeans. And the variant allele fraction is at that 53%, so consistent with a germline mutation potentially. There were also 2 variants identified in the TP53 gene, and one of them, the variant allele fraction, was 57%, so also hovered around that 50% allele fraction. But remember that most TP53 variants are not germline. I'll just go over what these 2 genes are associated with briefly. So the CHEK2 gene is mostly associated with breast cancer, up to about a 39% chance lifetime risk of developing breast cancer. It's also associated with an elevated risk for colon cancer, as well as some other cancers, including thyroid and prostate cancer. This is an example of a moderate penetrance or a moderate risk gene, and the management for this gene starts at age 40 unless family history suggests starting screening earlier, and that would be starting increased breast screening and colonoscopies at age 40. I did want to point out that the patient I mentioned, her family history is consistent with CHEK2 related cancers. There was breast cancer, there was colon cancer. The patient was 35 at the time that we saw her, so this would have implications on her screening a little bit later, so starting at age 40 if it was confirmed to be a germline mutation. And at this point, there was no specific link that we could find between the development of the astrocytoma and CHEK2. That link has not been defined or described. The TP53 gene is associated with Li-Fraumeni syndrome in a germline sense. As you probably noticed throughout this presentation, TP53 mutations, somatic mutations, come up a lot, and it's a very common somatic mutation in tumors. You might have heard of the TP53 gene as the guardian of the genome. Whereas someone who has a germline mutation, it's associated with Li-Fraumeni syndrome, which is a very rare syndrome. And it's really associated with quite a high cancer risk in really all over the body. There is an association with Lymphoma syndrome with brain tumors, so it is important to know in this patient's case if the TP53 mutations were if either of them were germline. Although usually TP53 mutations are somatic only. And this could be really important for the patient because the management is super extensive. It includes whole body MRIs because of the extensive cancer risk. And there's also radiation sensitivity. So that might have impacted how the patient's brain tumor was treated. It's typically recommended if there is an alternate treatment that is just as effective to avoid radiation for patients who have Lymphoma syndrome. So the patient's germline results came back and only confirmed the CHEK2 mutation. The patient was tested for on a large multi-gene panel for hereditary cancer risk. And again, this CHEK2 variant is probably not the explanation for the patient's clinical history or why her brain tumor developed. Importantly, that the patient does not have Lymphoma syndrome. So both of those TP53 mutations were not identified to be germline, even though one of them was close to that 50% allele fraction. And the germline lab actually reviewed the somatic report and was able to comment on each of the variants that I discussed and clearly note on the report if it was detected or not detected in the germline sample. So a summary of kind of everything we went over. So when determining based on a somatic result, if a variant is germline, it's important to consider what gene the variant is in, as well as the variant allele fraction, but I kind of went through that it's not a great predictor, and the various limitations of the somatic test. So there's differences in classification or nomenclature. So is the variant pathogenic or likely pathogenic versus a variant of uncertain significance in the germline versus somatic sense. And it's important to note the differences in technology. So if the gene was completely sequenced or deletion duplication analysis was performed. And then it's important to think about a somatic variant if it's actually related to the patient's tumor development or if it might be what we call an incidental finding. So remember that personal and family history warrants a referral to genetic counseling and for germline genetic testing, regardless of the somatic result, and that's because of the many limitations and nuances that I discussed today. So in conclusion, all of this is really, really complicated. So if you ever have any questions about when to refer patients to us or want us to review a somatic report so that we can see if there might be germline implications, please reach out to us. All of our contact information is on this slide. Many of the cases I went through, we ended up seeing in our clinic because the surgeon or the oncologist emailed one of the cancer genetic counselors, so we're definitely here to help. So our personal emails are on this slide, as well as our office's information for how patients can schedule an appointment. During this time, we're seeing most of our patients through telehealth video visits, and we also have a new telegenetics initiative where we can set up programs with specific providers or offices to offer virtual genetic counseling services. And our practice manager's contact information is on this slide if you had more questions or want more information about that initiative. And again, let us know if any questions come up as you're seeing these reports. It's definitely getting more and more common to do somatic testing, and we're definitely here to help in terms of the germline implications.